Okay, it's 8 o'clock, so we're going to get going. Perhaps I'll ask all these sites to mute their microphones and welcome everybody to Journal Club. We're going to start with Dr. Elena Miller's presentation on subclinical hypothyroidism. This is Dr. Miller's second Journal Club presentation. It's now old hat or a veteran, and we look forward to your presentation. Take it away.
Okay, thanks so much, Dr. Gandel. Good morning, everyone. So I'm presenting a paper. It's called The Association Between Levothyroxine Treatment and Thyroid-Related Symptoms Among Adults Aged 80 Years and Older with Subclinical Hypothyroidism. And it was published in JAMA October of this year. And the reason that I chose this paper was because it's within our population, 80 years and older, but also we screen for thyroid disease commonly when looking for the etiology of delirium or dementia. So I have no conflicts of interest. My objectives today are to outline the literature on management of subclinical hypothyroidism in older adults, to review the study's methods and results, and to provide critical appraisal of the study and initiate discussion on its implications. So some background. Subclinical hypothyroidism is defined by elevated TSH and free T4 within normal range. It's diagnosed solely based on thyroid function testing, and most people are asymptomatic. It can affect about 10% of the population. The highest prevalence is in women and the elderly. It's often caused by autoimmune or Hashimoto's thyroiditis. And this is a graph demonstrating that TSH increases with age. On the x-axis is TSH values, and the green line are people over 80. And it's compared to younger people with the blue and red line. And you can see that people over 80, the graph is shifted to the right. So TSH increases with age. And these are people without thyroid disease. The percentage of the population increases, the TSH increases with age, but also the percentage of the population with TSH over the upper limit of normal increases as we age. So in the 80+ population, the bar graph on the right demonstrates that 10% of people over 80 have high TSH. And when people have subclinical hypothyroidism, there's two ways that things can change over time. One is that they can progress to overt hypothyroidism, and so that's the right portion of the graph, and that happens in 1 to 5 cases per year. In 1 to 5% of cases per year, or most commonly, people revert to the euthyroid state. So it seems like people can go in between this euthyroid and subclinical hypothyroidism state many times because it changes. And so when thinking about what causes progression to overt thyroidism, the presence of TPO antibodies increases the probability of progressing to overt thyroidism. And that happens in people 4 to 5% per year if they're positive for these antibodies. And the higher the TSH, the greater the probability of transitioning to overt hypothyroidism. So 85% of people with TSH between 15 and 20 will progress to overt hypothyroidism within 32 months. So why do TSH values sometimes normalize on subsequent testing? Well, there's physiologic variation in TSH secretion, drugs, especially lithium and amiodarone, autoimmune diseases, and interference with the TSH assay. So there is some debate as to why TSH increases with age. Most people will agree that there's a genetic set point that affects thyroid releasing hormone, thyroid stimulating hormone, T3 and T4. And then there's two theories. The first one is acquired central thyroid hormone resistance, which is a decreased pituitary responsiveness to T3 and T4 with age. So TSH and T4 rise in parallel to a new set point. And then the second theory is that really this is early hypothyroidism, and the thyroid has great regeneration potential and can compensate well in mild disease. So what are the harms associated with some subclinical hypothyroidism? It can cause LV diastolic dysfunction, elevated triglycerides, elevated LDL, and elevated total cholesterol. And if you have a higher TSH, in this case, if a person's TSH is between 10 and 19.9, a meta-analysis demonstrated increased risk of coronary events, heart failure, and mortality. There is some conflicting results regarding cognition. This is a paper out of Italy from 2015 that found that subclinical hypothyroidism was associated with an increased risk of dementia in their subgroup analysis looking at people under the age of 75. But when they looked at the composite endpoint, including people who were under and over 75, the results were not significant. And then came a JAMA review in 2019 that demonstrated no statistical difference between a subclinical hypothyroidism and cognition. So the same meta-analysis showed that subclinical hypothyroidism has no statistically significant effect on fatal stroke, AFib, hip fracture, any fracture, non-spine fracture, or spine fracture. And so there are some harms with thyroid replacement. This was an interesting paper where they took people on thyroid replacement, and at one point in time they looked at their TSH, so one snapshot, and actually only 45.2% of those people were euthyroid. And so we're not very good at replacing thyroid hormone. And the caveat to this is that some people may have been in a titration phase, but still in this particular paper, almost 40% of people were over-suppressed, and that has its own consequences. If, excuse me, the TSH is overcorrected, there's an increased risk of vertebral fracture and hip fracture, although in this particular paper it was looking at women only, and then an increased risk of AFib in both men and women. So what about symptoms? This is something we think a lot about in our geriatric population. And this was a paper looking at subclinical hypothyroidism and symptoms in people under the age of 60 and over the age of 60. And they found actually that the frequency of symptoms decrease with age. And in the population over 60, they found that they had more periorbital puffiness, slow movements, hearing impairment, and dry skin. But obviously these are very non-specific symptoms. And the only symptom that was significantly more represented in the 60 years and older group was hearing impairment. So this is a paper from JAMA, published in 2018, looking at whether hormone replacement improved quality of life or symptoms. And it included 21 RCTs with almost 22,000 participants. And they found there was no significant effect on quality of life, hypothyroid symptoms, depressive symptoms, cognitive function, muscle strength, hand grip strength, and BMI. Then was the TRUST trial in 2017, and there was a lot of enthusiasm about this one. And it was a randomized double-blind placebo-controlled trial looking at adults 65 years and older with subclinical hypothyroidism, hormone replacement versus placebo, and they found no significant difference in hypothyroidism and tiredness score. So now we come to the main event, the study that I'm going to tell you about. It was a randomized, double-blind, placebo-controlled trial. And it was a parallel group trial, including the IEMO study, which is the Institute for Evidence-Based Medicine in Old Age, and the subgroup of over 80 years in the TRUST trial. The purpose of the study was to look at the effect of levothyroxine treatment in subclinical hypothyroidism in people 80 years and older. So in the IEMO trial, they looked at community dwellers aged 80 and over between May 2014 and 2017 from the Netherlands and Switzerland. And the TRUST trial, which looked at community dwellers aged 65 years and older from sites in the Netherlands, Switzerland, Ireland, UK between 2013 and 2015. And participants were followed for 12 to 36 months. The inclusion criteria was being over 80 and having persistent subclinical hypothyroidism. And so this meant having a TSH between 4.6 and 19.9 on 2 or more occasions. And of course, we know that it can fluctuate and people also often become euthyroid in that time. Participants were identified by a list of patients' lab tests from the hospital and primary care practices. Exclusion criteria was medications, levothyroxine, antithyroid medications, amiodarone or lithium, recent thyroid surgery or radioiodine therapy, NYHA class 4 heart failure, dementia, recent hospitalization for major illness, recent acute coronary syndrome, acute myocarditis or pancarditis, or terminal illness. The randomization and blinding. So people were randomized 1-to-1 to receive levothyroxine or placebo, and randomization was performed separately for each trial. The intervention group was levothyroxine 50 micrograms daily, or a lower dose if people weighed less than 50 kilograms. And doses were adjusted by 25 micrograms with a goal of reaching a normal TSH. TSH was measured 6 to 8 weeks after starting the intervention and 6 to 8 weeks after each dose adjustment, and at 12 and 24 months follow-up. And lab test results and study medications were blinded and determined by an algorithm. The control was a matching placebo, and they followed an identical schedule for the adjusting of the dose to achieve an equal number of titrations to maintain the blinding. So the primary outcomes measured at 12 months and end of study are hypothyroid symptoms and tiredness score. And this was based on a survey of the ThyPro, which it's been used in many studies. and it is an 84-item survey looking at 12 domains. They use the Danish form, as there's many different forms, and it's clinically valid and has good retest reliability. So the secondary outcomes that were evaluated are the change in TSH levels, general quality of life, hand grip strength, weight, and BMI, blood pressure, free T4, incidence of falls, Barthel index for ADLs, older American resources and services for IADLs, executive function, living situation, and gait speed. So almost 3,000 people were assessed for eligibility. And in the end, 251 participants were randomized, and that's 105 in the IEMO trial and 146 in the trust. And due to failure to stratify randomization by age in trust, actually in the levothyroxine group, they only had 60, and there were 86 in the placebo. And by the end of study analysis, there were 93 participants in the levothyroxine group and 124 in the placebo group. So these are the baseline characteristics of the participants. There are a greater percentage of men than women, 53.3 and 52.5. And this was a predominantly white group, 100% in the levothyroxine group and 98.6 in placebo. And they were not taking very many medications. In the levothyroxine group, 5, and in the placebo group, 4. And they are cognitively quite intact with an MMSE score of 28. And their baseline TSH was 6.4 and 6.3 in the placebo group. So not that high in terms of subclinical hypothyroidism range. So the results. At 12 months, there was a statistically significant difference between TSHs in the levothyroxine group and placebo group. And this is a graph. The dark green box represents levothyroxine, and the placebo group is white. And you can see that the white remained relatively stable, and the levothyroxine group is statistically lower TSH. In addition to the statistically significant TSH, they also found that weight increased in the levothyroxine group, and so did BMI. In terms of the primary outcomes, though, there was no statistical difference in hypothyroid symptom scores or tiredness scores. And there was no statistical significance in the any of the secondary outcomes at the end of the study. And according to the authors, they felt that the statistically significant increased weight in BMI in the levothyroxine group was likely due to chance, as the associations are small. In terms of adverse events, there were no increase in fatal or non-fatal CV events in the levothyroxine group, and no increase in overall mortality. 73 participants had serious adverse events, 33 in the levothyroxine group and 40 in the placebo group. And hypothyroidism did not occur in any patient. And 31% of treatment was discontinued in the levothyroxine group, and 34% was discontinued in the placebo group. So in conclusion, the levothyroxine treatment for subclinical hypothyroidism in patients over 80 was not associated with improvement in hypothyroidism symptoms or fatigue, and there was also no increase in risk of adverse events or secondary outcomes in the levothyroxine group. So critical appraisal. In terms of internal validity, this is a randomized, double-blind, intention-to-treat trial. The intervention and control groups were treated similarly. And at 12 months, 12% of controls and 20% of levothyroxine participants were lost to follow-up. The funding was based on research grants entirely for both trials, and Merck provided the levothyroxine pills and the placebo pills. In terms of external validity, so does this apply to our population? Well, these were people over 80, so yes, it does apply to our population. And I didn't feel that the people that we're seeing would have an average MMSE score of 28, so maybe that was a bit high for us. And I would say that our patients are on more than 5 medications. The strengths of this trial, it's randomized, and it looks at the geriatric population, and they seem to make a good attempt to capture those who had persistent subclinical hypothyroidism because the lab value had to be proven on 2 occasions. The weaknesses, it's small, only 251 participants. The TSH was low at baseline, only 6.4 and 6.3 was the mean. And there was no subgroup analysis with people with high symptom burden or high TSH. The TPO antibody status was not determined because that would be a sign they'd be more likely to convert to overt hypothyroidism. There was race homogeneity, equal men and women. Actually, there was more men than women, and really there's a female predominance of thyroid disease. And quite a few people discontinued treatment, 32 by the end of study, and so this may have biased results. However, the number and reasons for discontinuation were similar between the 2 groups. So when I was coming up with my own opinion of what does this all mean and how can we apply this to my clinical practice, this was an editorial that I really liked, and it was a persuasive one for me. And this was an editorial that suggests that we should increase the TSH upper limit to 7 for patients over 80. And this is to align TSH range with threshold for treatment, and to make TSH range easily interpretable, which I think is even more important now that our patients have access to the patient portal. And to use evidence-based data to establish a TSH range, to avoid polypharmacy in a vulnerable population, and to create a common TSH target for those with subclinical hypothyroidism not on treatment and those who require initiation. So this was something that resonated with me, and I tend to agree. I think we should increase the TSH upper limit to 70 in people over 80. And so in conclusion, consistent with earlier trials, there's no benefit to treat subclinical hypothyroidism in patients over 80. Do you have any questions?
Thank you very much, Elena, for the great presentation, great background, and very clear. I'm going to move on to the short presentation and look forward to hearing about physical activity, potentially another benefit of physical activity.
Thanks, everyone. So I'm Jessica.
If I can remind everybody to mute their microphones during the presentation. Thank you.
Can everyone hear me and see the presentation? Okay. So I'm Jessica.
Yes.
Okay, trained in family medicine, and I'm doing an extra year in care of the elderly. So I'm looking at physical activity and risk of post-op delirium. I don't have any conflicts of interest. So just a quick background. So postoperative delirium can occur in upwards of 61% of older adults who undergo orthopedic surgeries. There has been an association with delirium increasing both morbidity and mortality. And there have been studies to show that regular physical activity can decrease the risk of delirium during a hospitalization. So the study I looked at was published in the Journal of the American Geriatric Society in August of 2019, and it was by the authors Lee et al. And again, it looked at physical activity and the risk of post-op delirium. So the study population they obtained, so they got English-speaking adults over the age of 60 who were undergoing elective orthopedic surgery from a joint replacement center in the Bronx. They initially enrolled 155 participants, and after some people withdrew or their surgeries were canceled, they ended up with 132 participants who were eligible for the study. They performed a secondary analysis of a prospective single-center cohort study, and then they wanted to look at the baseline physical activity with the rate and the severity of postoperative delirium in this population of elderly patients who underwent elective orthopedic surgery. So they essentially wanted to see if increased physical activity decreased the risk of post-op delirium, and they wanted to look to see if this was independent of cognitive reserve, which I'll explain in a minute. So again, the inclusion was English-speaking adults over the age of 60 undergoing elective orthopedic surgery. They excluded anyone with baseline delirium, anyone that had dementia that was diagnosed by a physician, anyone that had an MSE score, a mini mental state exam score of less than 24, and anyone with severe auditory or visual deficits. For their primary outcome, they wanted to see how many people ended up getting postoperative delirium. So they used the confusion assessment method, the CAM, and they looked at both postoperative days 1 and 2. They tried to screen for day 1 kind of after 22 hours to make sure they weren't confounding with kind of wearing off of anesthesia or pain medications. If they screened negative for CAM, then they did a chart review to see if there was any sign of agitation, confusion, or any sign of altered mental status. The secondary outcome, they wanted to see how severe the delirium was to see if there was a difference there. So they used the MDAS score, so the Memorial Delirium Assessment Scale. All the screens were performed by one blinded investigator, and they also had a senior neurologist look at all of the assessments to kind of give it the okay in the study as well. Their primary predictor, so they used this validated leisure activity scale, the LAS. So they administered this anywhere from 18 days plus or minus 15 days before the day of the surgery to determine the participant's baseline physical activity as well as cognitive function. So they looked at, I listed all the activities that they included. So there were 6 physical activities and then 12 cognitive activities. They essentially had the participants rate the frequency, so if they did it on a daily basis, weekly, monthly, etc. And then they assigned a point to each one. And then they used a multiple linear regression to determine the role of physical activity on the development of post-op delirium. And they adjusted for age, sex, cognitive reserve, and they used the CCI, the Charlson Comorbidity Index. And they also looked at whether physical activity predicted delirium severity, again, controlling for these factors. So this is a busy slide, but essentially it just gives the baseline characteristics of the study population. So they used covariates that were established kind of risk factors of delirium, so things like depression, cognitive impairment, etc. So you'll see, and then I just listed the tests that they used to analyze the data. So you'll see that it was actually a fairly young cohort. So the median age was 70.5 in the trial, and they actually had quite a few more females compared to males. So they had 85 females compared to 47 males. When you look at the number of people who ended up developing delirium, so they had 61% of the females or 61% of the people who developed delirium and 39% of the people who developed delirium were women and men, respectively. When you look at the Charlson Comorbidity Index, you'll see that they were actually a fairly healthy cohort. So most of them had a CCI of either 0 or 1. They did find there was a significant difference between when they looked at the geriatric depression scale. So you'll look at this line here. So you'll see that people that scored less on the GDS had a decreased likelihood of developing delirium. And they found similar results when they looked at the mini mental state exam score. So people that had a higher score were less likely to develop delirium. And both of those were significant. They also found a significant difference when they looked at cognitive activity. So they used both a continuous scale and a dichotomized scale, which I'll talk about in a little bit. And they found that the more cognitive activities that you did in a week, the less likelihood of developing delirium down the road. One thing I would say is they did look at the type of anesthesia they used, so whether it was general, spinal, epidural, etc., and there wasn't a significant difference that they found in the types of anesthesia. So these are the primary outcomes. So again, they use the logistic regression model. So I'll kind of go through the models here. So if you look at the first model, they used physical activity and cognitive activities on a continuous basis. So they did find that for every unit of cognitive activity done during the week, that was associated with an 8% lower odds of post-op delirium. So they had an odds ratio of 0.92 here. When you look at the second model, they used physical activity and cognitive activities as a dichotomized scale. So cognitive activities, they described as anything significant over 21 activities in a week. And physical activity, they used 6 to 7 days of physical activity in a week. So again, participants that engaged in 6 to 7 types of physical activity per week had a 74% lower odds of developing delirium. And they also found that there was an 81% lower odds of post-op delirium in participants who engaged in regular cognitive activities. In the third model, they wanted to see whether a decreased number of physical activities was still significant. So they looked at 5 to 7 days of physical activity in a week. It was significant, but borderline with a p-value of 0.05. And so they found about a 65% lower odds of developing delirium. And in the fourth model, they took out cognitive activities to see if it was still significant with physical activities. So they found that there was minimal change in the odds ratio for physical activity when they looked at cognitive activity, or when cognitive activities were removed. And then they did say that regular physical activity and cognitive reserve had no significant interaction, so p-value of 0.7, indicating that they're independently associated with the risk of post-op delirium. So they also want to look at the impact of sex on risk of post-op delirium. So this chart in the blue, it looks at people that engaged in physical activity 0 to 5 days per week. And the yellow, it looks at 6 to 7 days per week of physical activity. With the men, you can see there really wasn't much of a difference, and they had a relative risk of 0.97, but there was quite a big difference that they found with the females. So they actually found that women who exercised or engaged in physical activity 6 to 7 days per week had a relative risk of 0.04 or 14 compared to those who engaged in less than that. And then they performed a logistic regression on that, stratified by sex, and again, they found significant difference. So they found an odds ratio of 0.08 here with women, but they didn't find any significant difference in the men who engaged in more physical activity. And then when looking at men versus women, there wasn't a significant difference in age or the CCI, the Charlson Comorbidity Index. So again, they also wanted to look at the severity of delirium to see if this had an impact. But they didn't actually find that people who engaged in regular physical activity, meaning those who engaged in physical activity 6 to 7 days per week, they had a median MDAS score of 4 compared to 5 in those who did not. So that was a p-value of 0.07. So the authors concluded that regular physical activity, so in their model defined as 6 to 7 days per week, decreased the odds of post-op delirium, so 73% lower odds, regardless of their cognitive status. So looking at cognitive reserve based on the number of cognitive activities they performed in an adult elderly population over the age of 60 without a diagnosis of dementia. They also found that women appeared to gain more benefit from engaging in physical activity in preventing post-op delirium. And there wasn't really a significant change in the severity of post-op delirium in participants who engaged in physical activity versus those who did not. So in terms of the critical appraisal, are the results valid? So did the cohort represent the general population? I said no, because I think, in my perspective, I would say the cohort was a bit younger and healthier than the general population. We're seeing a lot of older people, a lot more complicated comorbidities. So I would say this population was a bit younger and healthier. Were the screening tools validated? So yes, they used a lot of validated methods, including the mini mental state exam, the confusion assessment method, and the geriatric depression scale. So they also validated this LAS, this leisure activity scale. Though I would say I looked back at their old studies that validated this, and the description of the scale is a bit different. So they used more cognitive activities in this scale compared to their previous studies. And there was also a difference in the scoring. So they didn't really explain that in the method section, but there was something I noticed. And there's also a challenge in accurately reporting the physical activity. So there's recall bias, there's misclassification bias, and then, you know, is somebody that walks half a block 6 times per week the same as someone who does high intensity interval training 6 times a week? So I think there's a bit of a difference there that wasn't really accounted for. And they kind of explained that, saying there was too much of a burden to get the participants to go through all that detail in the study. And then were the methods for determining outcome consistent? So yes, so there was one blinded investigator who did all of the CAM assessments, and they used the validated tools. So were the participants blinded? So no, this was a prospective cohort study, so they weren't able to blind the participants. And were all relevant confounding variables identified? I think yes, there was many covariates that were established risk factors, and they included those in the analysis. And was there follow-up? So there was the follow-up on post-op day 1 and 2, and that was around 22 hours and then 32, 33 hours after their operations. And what were the results? So it was a small sample size. There's almost double the amount of women compared to men. And the study was underpowered, so they stated that there's a 35.7% power to detect about a 15% effect size with their study population of 132. And they did find the significant result with women who participated in more physical activity compared to men. You know, the question is there a true difference and increased benefit with women who exercise compared to men? Or is this a misclassification bias, kind of what I was talking about before? Or is it because there was more women compared to men? And is it just due to chance or unmeasured confounding variables? And they also talk about these studies that were done previously by authors who looked at whether increased estrogen and regular exercise may actually lead to neuroprotection and decrease the risk of post-op delirium. But these are just kind of things that they were thinking about. And just to note, I did find some errors in the text. So when they were describing the results, a few of the numbers were actually different compared to the charts, just slightly a few numbers off. So just to note in the chart. So how precise were the risk estimates? So they used a 95% confidence interval, and the significant results did have larger ranges of confidence intervals. And the results, are they applicable to my patient population? So I think yes. So I think it's realistic that patients that are chosen for elective surgeries, especially orthopedic surgeries, you know, more likely they would be maybe younger and healthier population. But again, looking at the general population, I would say it's probably a bit older with more comorbidities. So overall, what the conclusions I would draw from this study? So being trained in family medicine, I always counsel my patients on physical activity no matter what the context is. So I think this just is another kind of tool in the toolbox to say, if you're going for a surgery, especially if it's a joint surgery, continue exercising. There may be some benefit to try and decrease the risk of post-op delirium. And then the other thing to think about is in these elective orthopedic surgeries, pain's probably quite a limiting factor since most of them are having joint pain and are limited to exercise. So this study may help to say just cognitive activity, so engaging in many cognitive activities during the week, does that help to prevent post-op delirium? So that's something else I can counsel my patients on. So these are the list of the references, and then that's it.
Great. Thank you again, Dr. Wilson. We're very grateful for that great presentation on short notice. That was excellent.